This is Dr. Rodriguez-Sevilla. I'm currently postdoctoral fellow at MD Anderson Cancer Center, and thank you for having me. So, myelodysplastic syndromes, we know there are clonal hematological disorders, which are usually higher incidence through elderly and are accompanied or are characterized by inefficient blood production, leading to cytopenias and a higher risk of IML transformation. So we do know, thanks to advanced genetic studies, that these disorders are originating in a disease and a small disease initiating hematopoietic stem cell, which alters the healthy microenvironment within the bone marrow. In this process, inflammation plays a pivotal role in initiation, but not only initiation, but also progression of MDS. We know that chronic inflammatory stimuli can disrupt the equilibrium between healthy hematopoietic stem cells and the altered or aberrant counterpart, and through a complex and dynamic cascade where inflammation plays a role in HSC's increased fitness, in metabolic rewiring, or its effects in the immune system can really have a role in this clonal evolution from premalignant or pre-leukemic stages, as we know now, CHIP, clonal hematopoiesis of intermediate potential, or CCOS, clonal cytopenia of the undetermined significance, to the progression of MDS. So yes, we know that inflammation through different roles and different effects can really have a role in MDS pathogenesis and MDS initiation. So since we know now this central role of inflammation in MDS initiation, there are several current clinical trials trying to target this pro-inflammatory or dysregulation that happens in MDS. Currently or recently, we have published from our experience at MD Anderson a phase 2 clinical trial of canakinumab, an interleukin-1 beta inhibitor led by Dr. Garcia Manero and Dr. Cola from the leukemia department here at MD Anderson Cancer Center, where we explore the effect of inhibiting this interleukin-1 beta, which is significantly increased in our MDS patients, in a cohort of low-risk MDS patients after failing the first line of therapy. The trial enrolled 25 patients. The majority of them had failed HMA. Actually, 80% of the patients did fail HMA failure, and 96%, all of the patients but one, had transfusion dependency. Canakinumab showed a favorable safety profile, and an overall response of 17%, which is not that high. But in some patients, we were able to achieve transfusion independence for over a year. What it was most interesting is that we had single-cell RNA sequencing analysis longitudinally and prospectively through the trial, and we were able to see that in patients with a lower molecular complexity, canakinumab was able to downregulate inflammation in the stem and the more mature cells. It was able to shut down NF-kappa B pro-inflammatory pathways and able to rescue erythropoiesis in our patients. Whereas in patients with a higher molecular complexity or mutations in splicing gene SF3B1 showed no response. Beyond canakinumab, there are currently other trials targeting, for instance, the NLRP3 inflammasome, IL-6, TNF-alpha. We have recently approved by FDA luspatercept in the setting of anemia for low-risk patients, for MDS, and this specific erythroid maturation agent actually plays a role in regulating inflammation for a better terminal differentiation of these patients. So together with that, there are also trials trying to target metabolic features of this inflammation dysregulation in the setting of MDS, such as vitamin C or V1-AIDs, where we're trying to kind of control the mitochondrial function of these aberrant HSCs in order to avoid their further progression or transformation into MDS or AML. So that is a great question. I believe that basic and translational researchers are doing a great job trying to dissect the really origin and source of this disease and all the different features in such heterogeneous group of patients that it's sometimes really hard to determine. And what I think is really important, just even before thinking about putting a patient into a clinical trial where we're targeting inflammation, is that something that we learned in our canakinumab trial is that we need better diagnosis and better stratification of our patients in order to kind of select better which patients might be prone to respond to a specific therapy. So for instance, in our experience, we saw that canakinumab was more effective in lower complexity molecular patients. So that might be something that for clinicians is important to really have the best of the best diagnosis, stratification, molecular and cytogenetics to try to select and try to the so-called tailor therapy for more personalized treatment for our MDS patients.